Good morning and welcome to the Coalition of Orange County Community Health Centers Coffee Connections event. We are thrilled to have you here today, virtually, on Zoom and through Facebook Live. My name is Isabel Becerra, President and CEO of the Coalition of Orange County Community Health Centers, and I will be your host and moderator for the event. For those of you joining us for the first time, Coffee Connections is a space where we can come together as a community to discuss critical health topics, share ideas, and inspire action. Today, we are focusing on maternal health, which is not only about healthy moms, but also about healthy families and communities. Maternal health is a critical issue that impacts the well-being of our entire society, especially as it intersects with systemic inequities. Mothers are often the backbone of families, and their health affects the next generation in profound ways. Unfortunately, we know that maternal outcomes in the U.S. are not where they should be. Research has documented that social and economic factors, racism, variation in quality healthcare, implicit bias, and chronic stress contribute to poor maternal and infant health outcomes. Social determinants of health prevent many people from racial and ethnic minority groups from fair opportunities for economic, physical, and emotional health. As such, the purpose of today's event is to discuss how we can address these inequities and create pathways to health equity for mothers. We believe that every person, regardless of their background, should have access to quality healthcare and the opportunity for a healthy pregnancy and birth. Our goal is to engage in a meaningful, action-oriented dialogue. Together, we can explore innovative strategies, share best practices, and think about how we can improve maternal health outcomes through partnerships and community efforts. Before we jump into today's vital discussion, let's cover some housekeeping guidelines. Please keep things professional and respectful. Let's steer clear of anything offensive, discriminatory, or disruptive. Feel free to dive into the conversation, ask questions, and share your insights. We thrive on diverse perspectives and constructive dialogue. If you have a question, please use the designated Q&A feature. This helps us keep things organized and ensures everyone's questions get addressed efficiently. We're committed to fostering a safe environment for all. Any comments or questions that are deemed inappropriate, offensive, or unrelated to the topic at hand will be dealt with immediately. We'll remove any inappropriate or off-topic content and, if necessary, take further action, including removing the participant from the event if necessary. We value your input, and after the event, we'll provide a short evaluation form so you can share your thoughts and suggestions for future Coffee Connections events. Now, to begin the event, I will introduce Dr. Michelle Chung, Maternal, Child, and Adolescent Health Director with the Orange County Healthcare Agency. Dr. Chung is a board-certified pediatrician and pediatric infectious disease specialist who has been with the Orange County OC Healthcare Agency for 20 years. Currently in her role as the Maternal, Child, and Adolescent Health Medical Director, she collaborates with community partners on initiatives to improve the health of the maternal, child, and adolescent population, provides clinical consultation and education for public health nurses, develops policies and procedures and other materials to guide staff, and conducts training for communicable disease surge responses. Dr. Chung, the floor is all yours.
Thank you. I'm going to share my screen. So thank you all for coming today. I see there's quite a number of people on the line, and to the coalition for inviting me here. I'm very, very excited to see that we're having this discussion. As Isabel mentioned, this is such an important topic, not just for maternal health and our children, but for the whole community, really. So my goal today is to set the background for this panel discussion to discuss how we together can collaborate to address disparities in maternal and child health outcomes and the inequities that impact these outcomes. Previously, when I've given talks about a lot of this data, I used news headlines to start it off, but I had the good fortune this week to listen to a presentation from our California Surgeon General, Dr. Ramos, who will be with us today later on. But she showed a video, which I thought would be perfect to start us off, as it really highlights a lot of the things we're talking about today.
Sanchez family is mourning a great loss while also celebrating the birth of a new baby. 19-year-old Ariana Sanchez died due to complications while giving birth to her daughters. The father, Ezekiel Esparza, says he still remembers the day he and Ariana found out that they were going to be parents.
But she was telling me, she was like, the line's not going away, babe. The line's not going away. She's the love of my life.
The idea that in one of the wealthiest countries in the world, the United States of America, we have the highest rates of maternal mortality, that Black women in our country in this era are 3 times more likely to die in connection with childbirth. I think it's inexcusable.
Once known as the world's fastest woman, Bowie died at her Florida home from complications of childbirth. The tragedy is resonating deeply with Black women who are at higher risk of dying while pregnant.
The circle of life begins with the birth of a child, and that journey begins with pregnancy. People who are pregnant or who have had a baby know their bodies and know when something does not feel right. When they speak, we must listen.
So I'm sorry about that. So today we're going to be talking about a lot of data about maternal and infant outcomes. Many of the disparities we see are regardless of education or income, and are due to systemic barriers, racism, access to care, like Isabel had mentioned. So I wanted to mention these federal goals, the White House Blueprint for Addressing the Maternal Health Crisis, that were released in 2022. If you're interested, you can look at the document for the details, but I really feel that they provide a nice framework for us to work on together locally. So as we go through some of the data, I'd really like for you to think about where in the systems you work that you might be able to affect some of these. And also on an individual level, when you're working and intersecting with these families, what are some actions you could take to help support these goals, such as the access to health care, including quality of care, not just for pregnancy, but preconception and postpartum too, addressing racism, implicit bias, and making sure the voices of our families are heard. Looking at data, you'll see when I'm presenting some of the data that there are gaps in terms of timeliness of when we can get the data, such as death data, and also for certain racial or ethnic groups for which numbers are small, so often are not reported out. This doesn't mean that these numbers aren't significant or that we can't learn from them. Every death of a mother or baby is tragic and meaningful and affects so many, so we really need to be paying attention to those numbers too, even if they are small. Looking at to diversify and expand the perinatal workforce, including more people of color, better cultural and linguistic sensitivity, incorporating other types of workforce, including doulas and midwives, and then also for social determinants of health, realizing that these all affect health and the stress that the family is experiencing and their ability to access care. So this data is from 2018 to 2021. In 2023, when this data from 2021 was reported out, we saw a lot of headlines about the increase in maternal mortality that had occurred in the years up to 2021. So maternal mortality rates here are per 100,000 births, and they're in the 42 days after the death of the woman while they're pregnant, or 42 days after termination of pregnancy, and for any cause, but not including accidental or incidental causes. So in 2021, we saw that the maternal mortality rate for non-Hispanic Black women was almost 70 deaths per 100,000 live births. And for Hispanic white women, they were dying at a rate of almost 27 deaths per 100,000 live births. So overall, the rate was about 33 women were dying out of 100,000 live births. So we can see that the rates in Black women were almost 2.6 times that for the non-Hispanic white women. And we also saw that the increases during that time period were for all races. So in 2022, we did see that the numbers went down, but I did want to point out that so this study is from the Commonwealth Fund study looking at maternal mortality and the maternal care workforce and composition, and it really compared us to other high income countries, Australia, Canada, France, Germany, the Netherlands, New Zealand, Norway, Sweden, Switzerland, and the UK. They also included Chile, Japan, and Korea because those are high income countries with universal healthcare systems. So even though things were getting better in 2022, these top lines, the highest death rates, were the top one here is US Black mothers, 49.5 deaths per 100,000 live births, sorry. The next one is the US overall at 22, again, way over everybody else, and then white and Hispanic after that. So all of our numbers are way over the other countries there. And all of these numbers also are over the the target for healthy people of 2030 of 15.7 per 100,000 live births. And this is looking at a little differently, where the x-axis here is now the countries. So in 2022, we saw that our US Black women were having death rates during pregnancy of several times over the other countries, and even all of overall, our numbers were higher than all the other high-income countries. So when we looked at why people were dying, this is 2020 in the US, and these are from deaths that are reviewed by the Maternal Mortality Review Committees in 38 US states. This is the most frequent overall causes were mental health, cardiovascular, infection, hemorrhage, embolism, and hypertensive disorders of pregnancy. And these 6 accounted for 82% of pregnancy-related deaths. When you looked specifically by race ethnicity, you see some differences for leading underlying cause. For Hispanics, it was infection, and that was mainly COVID-19. For non-Hispanic Asians, it was amniotic fluid embolism. For non-Hispanic Black mothers, cardiovascular conditions. And for non-Hispanic white mothers, it was mental health conditions. So really, during this time, this was a big shift that year. Infection came up higher because of COVID-19 as a leading cause of death, especially for Hispanics. The Maternal Mortality Review Committee looked at whether or not, like I mentioned before, whether they were associated with pregnancy, but also whether they thought they were preventable. And so when they looked at the 2020 deaths, 83.5% of them were deemed preventable, meaning that they could be averted by one or more reasonable changes to patient, community, provider, facility, and/or systems factors. So like the video mentioned, a lot of our deaths are preventable with things that we can work on. The other thing the Commonwealth study looked at was what percent of births were at different time periods. So as you see here, nearly 2/3 of maternal deaths in the US occurred in the postpartum period. So a lot of them are here in the 7 to 42 days postpartum, and a lot of them after that. But really, the World Health Organization recommends at least 4 contacts in the 6 weeks following birth, but about 40% of women skip that postpartum checkup, especially young women, low income, and uninsured. Our extended coverage for postpartum for 12 months with Medi-Cal can help to address this, but there's also opportunities here to improve access and utilization of those postpartum visits, including transition to the routine care providers, looking at this as the 4th trimester approach, looking also to preconception care for the next baby. So this graph is looking at providers, including OB-GYNs in the dark color, and then the light color is midwives per 1,000 live births. And since I mentioned before, nearly 2/3 of maternal deaths in the US occurred during the postpartum period, the US women are less likely to have supports such as home visits during that time period. And so in addition to providing care during pregnancy and delivery, the midwives also provide postpartum care, help to manage some of the relationship building social needs during that time period. We are fortunate here in California that we're not in a maternity care desert, but in the US, as you see, we have the lowest rates of providers per 1,000 live births. And we really have the opportunity to expand and diversify our workforce, including expanding the use of midwives and doula support. This is a table looking at what the different countries I mentioned, the high-income countries, and whether or not they cover home visits. It's so important, again, as I mentioned, for high-quality postpartum care. And since families don't always go to their visits, those either midwives or nurse visits or doulas can be associated with improved mental health and breastfeeding. They can help address mental health concerns, maternal issues, different supports and social drivers of health, including housing, food, financial security, and protection from domestic violence. So if you look at this table, all these other countries, and here at the bottom, everywhere else, the home visits are covered by national insurance, but in the United States, they're only covered with certain health plans and by some state Medicaid plans. So I'm looking a little more carefully at our California data. So this uses a slightly different definition for deaths, where the pregnancy-related mortality ratio is defined as deaths while pregnant or within 1 year of pregnancy, and some of the other data I mentioned was within 42 days. And then this can be through any causes related to or aggravated by pregnancy, but does not include deaths from suicide, homicide, drug overdose, or most other injuries. So in this table here, the graph here, the green line is US, and the blue line is California. You do see that our numbers did go up. More mothers died. A lot of it was due to infection, specifically to COVID-19. And then here on the map, you can see Orange County, and this is over a different time period, 2017 to 2021, because our numbers are small. They did combine a bunch of years. There were 22 deaths during that time period, and the overall rate was 13 deaths per 100,000 live births. So again, even though the numbers are small, we have to remember that every death in a mother is significant and affects their partners, their other children, family members, and not to mention friends, neighbors, coworkers. So looking again at the timing issue, 61% of the deaths were after the first day of delivery, again, emphasizing in California the importance of the postpartum visits, either with their primary care provider, their OB-GYN, or with a home visiting staff. And then looking by race ethnicity, we can see for California, whoops, I switched the thing there. For California, the rates of deaths in Black mothers, 49.7 over 100,000 live births, a lot higher than we see for the other race and ethnic groups. Down below, we're looking by different regions. Again, our numbers are combined with other counties because the numbers are small. So Orange County, our region, is doing a little bit better than some of the other ones. We have smaller numbers of deaths and a lower rate. But again, all these deaths are extremely significant and reflect on the health of our population in general too. So now looking more specifically at Orange County. So these are looking at maternal morbidity, which is 20 different indicators that are serious complications of pregnancy or delivery, like sepsis, respiratory distress, cerebral vascular disorders, pulmonary edema, heart failure, and that result in serious short or long-term health consequences, such as ventilation, hysterectomy, prolonged hospitalizations. So this data is per 10,000 delivery hospitalizations. You can see here, we are in green, California is in blue. And just to note, our number here, 87.7 per 10,000 delivery hospitalizations, that's above the healthy people target. So here, and again, not only that, are we above the healthy people target, when we look at different races and ethnicities, there's a huge discrepancy here where our Black mothers are affected much higher by these severe complications than our other races and ethnicities. And on the graph on the right, you can see over time that everything's increasing a little bit, but our rates in Black mothers much higher. So different health conditions such as asthma, diabetes, and hypertension that are experienced before, during, and after pregnancy can be associated with poor maternal and infant outcomes, such as increased risk of preeclampsia, preterm birth, low birth weight, birth defects, and infant death. So realize that these chronic health conditions are also all affected by access to care, preconception care, quality of care, and can be affected by different factors that affect those as well. So looking at asthma, over time, we're again in green, California in blue. All the rates of asthma delivery are increasing, and specifically we're seeing higher rates in our Black mothers. For diabetes, again, we are seeing increases over the years in all the different races and ethnicities, but specifically our Asian and Pacific Islander population seems to have higher rates. There's a lot of opportunity for education, monitoring, and support. Most of this higher rates of any diabetes at delivery is due to gestational diabetes, as the pre-pregnancy diabetes rates are very low, only about 1 to 2%. And then looking at hypertension, this again increasing over time. We see that there's highest rates in any hypertension and delivery in our Black mothers. And then there's either greater disparity with chronic hypertension, although it's less frequent. And realize also that hypertension during pregnancy leads to increased risk of chronic hypertension and heart disease later, so affects them later in life as well. For our mental health issues, for prenatal and postpartum depressive symptoms, we see that here in Orange County is in green. This is prenatal over here on the left and postpartum on the right, and California is in blue. On the maps, the darker color shows higher percentages. So 15.1% of pregnant women reported experiencing prenatal depressive symptoms. And then 11.2% reported experiencing postpartum depressive symptoms. And then when we looked by race ethnicity, the rates of depression symptoms are highest among Asian and Pacific Islander pregnant or postpartum persons and lowest among whites. So a lot of these factors, as I mentioned, can lead to and in combination with access to care, racism, and effects of social determinants of health, these can all help lead to preterm births. These are rates averaged over 3-year time periods, and we can see that our rates are highest in our Black babies. Overall, our rate is 8.3%. 8.4%, even though these are averaged over 3 years, but just note that we have been seeing an increase in preterm births overall. So we really need to keep an eye on this. It seems that during the pandemic years, we did increase quite a bit. And preterm births, of course, can lead to further hospitalizations, developmental issues, other hearing and vision sequelae, and the care really affects the family of these babies. Low birth weight also, we're seeing an increase overall since 2020. Babies with low birth weight have similar complications, as I mentioned, with preterm birth, hospitalizations, and the outcomes, the care of these babies can affect the family. So we see here again that our babies, Black babies, have the highest low birth weight percentages. Looking at fetal mortality, this is the health of the mother, of course, affects the mother herself, but the health of the mother also affects the baby, and it can affect fetal mortality. This is the spontaneous death or loss of a fetus during pregnancy, at least 20 weeks of gestation. Some of the risk factors include hypertension, diabetes, infection, as well as childbirth complications. So we've had 122 fetal deaths in 2022, with most of them being from placenta, cord, and membrane complications, unspecified or maternal complications, and the highest rates of fetal mortality were in our Black babies. Looking at infant mortality overall in 3-year time periods, in Orange County, we can see the blue, we had the highest rates in our Black babies dying, but this did increase over the time periods between 2014 and 16 and 2020 to 2022. Overall, our rates have increased in the past few years, and we'll have to continue to monitor that over time. So we've seen a lot of disparities in outcomes. These have persisted. We see Black women and birthing people more likely to die from pregnancy-related causes than other women. Black infants twice as likely to die than white infants or other racial groups before their first birthday. In looking at the data also, the higher socioeconomic status is not a protective factor for adverse birth outcomes for Black women and birthing people. So a lot of things to ensure the optimal perinatal experiences for everyone include addressing racism and implicit bias, access to care and quality care, including preconception and postpartum, by a workforce that is culturally and linguistically sensitive, and ensuring data is available in a timely manner to identify trends in areas and populations needing prioritization. So I showed you the federal goals earlier, but now let's look a little bit at some of the work that's being done more locally. In California, they produced a report centering Black mothers in California that really looked at how structural racism has affected our Black maternal and infant health and different the effects of discriminatory policies, chronic stress, and lack of access to high quality, respectful healthcare. Our Department of Healthcare Services is developing a birthing care pathway to reduce maternal morbidity and mortality and address significant racial and ethnic disparities in maternal health outcomes. And the report is expected to be released pretty soon. Other things at the state level, of course, our Medi-Cal benefit has been extended to 12 months postpartum. There's the doula benefit. Our California Department of Public Health also has a pregnancy mortality surveillance system, as well as a pregnancy-associated death review committee. Dr. Ramos, I'm sure, is going to talk more about her initiative, the Strong Start and Beyond, but I did want to point out this quote, which really resonates with me as a pediatrician, but that the best investment to ensure the health of a newborn is to ensure the health of the mother, and really that extends to the health of all of our population, not just mothers and infants. A sample of some of our local perinatal collaborations, our Orange County Perinatal Council works to support optimal perinatal health and wellness for all of our Orange County birthing persons, mothers, and babies. The Regional Perinatal Programs of California works with our birthing hospitals to provide education and support to ensure pregnant women and babies have access to the level of care they need to reduce adverse perinatal outcomes and eliminate disparities. HCA and CalOptima have been working together looking at SMART goals for maternal depression to promote prenatal and postpartum depression screenings by providers and to connect them to follow-up care. Our Orange County Home Visiting Collaborative is increasing awareness about home visiting, developing a coordinated entry system to ensure families are able to get quality services appropriate to their needs and preferences. Our Family Support Task Force is working on implementing family wellness plans to support families affected by perinatal substance use. And then our needs assessments for the community, as well as our Community Health Improvement Plan and Population Health Collaborative, are addressing some of the needs identified such as access to care, mental health, and social determinants of health. We did have a birthing justice screening last year, which really kicked off some of the momentum and discussions on ways we can address this disparities and change healthcare systems. The First Five, as well as Moms and Her Story, worked together on a community-based doula pilot to have a doula program specifically for the BIPOC community. They were able to pair 20 BIPOC pregnant persons between 2023 and 2024 to a doula, as well as provide them with educational classes. We have a bunch of home visiting programs at the agency and in the community ready to support pregnant and parenting families. We also are going to be implementing soon our Black Infant Health Program in collaboration, HCA and First Five, to improve health among African American mothers and birthing people and babies, to reduce disparities in maternal infant health, and empower women to make healthy choices for themselves and their families. This is going to look at a group model, to really address some of the social factors that play a key role, and look at reducing stress, increasing social support, building empowerment of the individuals and communities, and improving health and social conditions throughout the life course. UCI has been spearheading the Black Pearl Initiative, which stands for Promoting Equity, Anti-Racism, and Love, and that's done in collaboration with First Five under a US DHSS grant. This looks at the pillars of the community, including doula care, patient outreach, health system, interdisciplinary perinatal care team, as well as a community advisory board and facilitated reflection, trying to reduce C-sections and preterm births, increase NE breastfeeding, increase doula-partnered pregnancy, delivery, and postpartum care, optimize awareness of health inequities and cultural humility in clinical care settings, and engage future health professionals to increase awareness and opportunities for service. There is a Birthing Joy Symposium coming up that's hosted by Black Pearl on October 16th, 2024, and you're all invited to participate in that. And I just wanted to end with reflecting on what brings me my birthing joy and continuous joy for the past 23 years. It really drives me to believe that everyone deserves the fair and just opportunity for an optimal perinatal experience, including pregnancy, birthing joy, and parenthood, if that's what they choose. And we do, here at HCA, we would love to collaborate with you more on any initiatives or projects related to maternal, child, and adolescent health. Thank you.
Thank you so much, Dr. Chung. This is incredible information that I'm sure our audience and participants, even myself, it was a shock to hear. I'm glad that we ended with a lot of opportunity for how to address some of the disparities that you've just outlined. And so with that, we will transition into the next part of our event. We're excited to introduce an engaging lineup for our coffee chat segment. So let's kick off with our moderated discussion. I'm going to ask each of our panelists to introduce themselves, and I'll start with Sarah Valancourt.
Awesome, thank you. You can hear me okay?
Yes.
Great, awesome. Well, thanks, Dr. Chung, for that really awesome kind of overview of health equity and some of the data that we're, concerned about. My name is Sarah Valancourt, and I am the outpatient quality improvement clinical lead for California Maternal Quality Care Collaborative. CMQCC is a perinatal quality collaborative for the state of California. And a lot of the work we've done over the years is to really reduce the morbidity and mortality that is preventable, for the most part at the hospital level. And throughout the last few years and looking forward, we're looking to expand work into the outpatient realm. So how can we kind of best promote health for moms and birthing people during pregnancy and postpartum? Clinically, I am a women's health nurse practitioner. My clinical practice has been at an FQHC for most of my career. So working in community health and with community clinics is kind of where my passion lies. And so I'm really excited to kind of get to talk about some of the ways that we can improve maternal health equity today with my other panelists.
Thank you, Sarah. We have another Sarah O'Rourke.
Good morning, everyone. I'm Sarah O'Rourke. I'm the Chief Program Officer at MOMS. And MOMS is a community-developed model that actually was developed out of a former maternal health crisis in Orange County about 30 years ago, when there was not enough care and prenatal care for low-income women in Orange County. So we primarily serve the Medi-Cal population, and that's largely, for us, the Latina population and Vietnamese population. But as Orange County shifts, so do our services. My background is in public health and social work, and I think that intersection of health and the social determinants of health is something that is really important for this conversation. And I know that we'll get into that as we move through this discussion. So very much looking forward to being with you all today.
Thank you, Sarah. And Christine?
Sure. Hi, everyone. My name is Christine Ivory, and just like many of my panelists here today, wear a lot of different hats. I am the founder and CEO of Public Health John, which I always say is represented by 3 C's: community, coaching, as well as consulting. So I have the opportunity to provide maternal health-based consulting for great organizations out there in the Philadelphia area and beyond, as well as coach the upcoming workforce in public health. We know that is extremely important, as Dr. Chung just mentioned. And then lastly, coaching those new professionals and those that are in the public health field or those who are pivoting, particularly around maternal health. I'm also a program officer at the New Jersey Healthcare Quality Institute, where there are 3 wonderful focuses around community health, around quality improvement, as well as policy. I am an adjunct professor at Thomas Jefferson University in Philadelphia as a child's health adjunct professor. So many different hats. And I'm looking forward to the conversation today, just as we look forward to advancing maternal health and really great strategies that we can all talk about together that could be actionable for the future.
Thank you, Christine. And I am also saddened to report that Dr. Michelle Rose, who was supposed to be with us here today, Chief Health Equity Officer at CalOptima Health, was unable to join us due to illness. So apologies for that. I think we'll still be able to have a great discussion. Thank you, everyone, for taking the time to introduce yourselves. So let's just dive right into it. The first question that I have for all of you, and we'll go in the order that that you all were introduced. What do you feel is the most critical barrier, and how might healthcare systems and communities work together to overcome them? So we'll start with Sarah Valancourt.
I muted myself. Thank you so much. So I think there's a lot of answers to that question, but I think a lot of them kind of come together with this theme of like really lack of service integration. So both kind of across sectors, so medical and community, public health, social services, but also even within the medical field. So I'll kind of answer this question from a medical perspective, recognizing my panelists have more of that community-based experience. I think a lot of room for improvement from the medical perspective is really starting to think about pregnancy care within the larger kind of spectrum of primary care in the lifespan. So we know that pregnancy is just one period of time that a woman or birthing person, seeks out for healthcare. So can we better integrate primary care, preconception care into pregnancy care? And then certainly into that postpartum period, because we are seeing that severe morbidity and mortality for pregnant people is really impacting our postpartum time period. And so what's really, great about FQHCs and community health centers is that they're particularly positioned to be able to do that integration effectively because our services tend to be already integrated. We're already providing primary care. We're already providing pregnancy and women's health care. We're already providing pediatric care, so we can take a dyad approach to postpartum. And so really thinking about how we're integrating, even within the medical system, these services, so we're not having to kind of relegate pregnant patients to a specialty, which really provides an opportunity for patients to get lost to care or not have the health promotion opportunities that would best serve a healthy pregnancy and postpartum period.
Thank you, Sarah. We'll move on to Sarah O'Rourke.
Thank you. I love that, Sarah, that you touched on really looking at this as a lifelong health outcomes. We're looking at not just pregnancy, but what's happening before the pregnancy, right? So the conditions that people are in when they are pregnant are often the conditions that they were in prior to their pregnancy. So thank you for highlighting that. I think for me, again, there's so many ways to answer this question, but what I wanted to talk about is this shift away from seeing birth as a normal physiological event. And I think this matters because it's not a condition that in a lot of cases needs to be managed medically. And I know that's a little bit controversial at times, but I think it's something that's really important to highlight because when we take the birthing person out of the driver's seat, we create this hierarchical relationship, right, between the healthcare provider and the birthing person. And this is not always the case. I know there are a lot of amazing providers out there, so I don't want to make this sound like it's individual providers are the problem. I think it's just the way that the system is set up. So I think really putting the birthing person back again into the driver's seat and looking at client-focused, client-centered care is really, really critical to advancing health equity. The reason I think this is important is also because when we see that hierarchical relationship, it exacerbates inequities that we're already seeing for communities that are experiencing more discrimination and adverse outcomes as a result of structural racism. So we know that Black women, Native women, women living in rural areas, and low-income women, and I would add to that women that have recently, and birthing people really that have immigrated recently, are all at risk of adverse outcomes. So I think, just kind of getting back to our roots, birth was not always seen as a medical event. And if you look at other cultures, there's a lot of cultures that celebrate birth as a rite of passage. They have birth keepers that are part of the community that have knowledge that's passed down through generations. And I think there's a lot of opportunities as we move forward to think about, and we'll talk more about this later in our discussion, but how does community-centered care support the healthcare system and vice versa? So not everyone needs to see an OB. There's a lot of opportunities for us to expand and look at midwifery care. And we have the great opportunity that when someone needs that higher level of care, how do we make sure that we have OBs that are trained in trauma-informed and culturally responsive care?
Thank you so much for that, Sarah. Christine?
Absolutely. I think that my answer will mirror a lot of what these great panelists shared just now. When I think about barriers and really dismantling those barriers around maternal child health, what I'm thinking about from a public health framework is social determinants of health, where we work, where we live, where we play. I know that many of us, if not all of us on the line, are very familiar with those words and that phrase and definition. And then taking it a step further, we know that, just as Dr. Chung mentioned in her presentation, thinking about transportation access, food access, access to medical care, quality medical care, that is extremely important. Where my mind goes a little bit further into the weeds on this is thinking about from an upstream, downstream, and then that midstream approach. So I think it's wonderful that we have great resources that are either being cultivated now or enacted at a downstream. However, I think from a public health perspective, I'm thinking upstream. What type of policies can we enact? How are we training our next generation of healthcare providers in our workforce? As Sarah O'Rourke just mentioned, thinking about how are we training around anti-racism training? How are we thinking about implicit bias and cultural sensitive and humility type of training that is ingrained in our practices and policies in our hospital settings as well as other settings as well? I'm also thinking about that workforce development. Do we have areas where, folks in high school or our youth in middle school even know that these opportunities exist, and how can they have their best access to that? And then I think number one, we don't necessarily talk about it enough, is preconception health, which both of these expert panelists mentioned, making sure that we are having programs, services, education around preconception health. I was talking to my students the other day just about how in high school, and they reflected the same response. They were told about how to not get pregnant, about contraceptive health, and all those great, aspects that are really great for high school students. But now at a time where they're thinking about family planning, what does that look like for someone that is in that preconception stage, and for the mother and the birthing person, but then also for the father and the partner as well? So really thinking about it from a landscape approach as we think about preconception health and making sure that those resources are available as well.
Thank you, Christine, and all of the panels. I think you bring up very critical aspects of how we may address, right, the structural racism and the gaps in care that our communities are facing. Unfortunately, I think overlapping or hovering above all of these areas is the dramatic workforce issues that we're facing, right? We'll probably talk about that as we continue through our discussion. So thank you so much. I'm going to ask about very specific questions for some of you. So for Sarah Valancourt, how can quality improvement initiatives be tailored to better serve marginalized communities, ensuring that maternal health outcomes are equitable?
Sure. And that's a fantastic question. And I think that question at this point really has to underline all of the quality improvement work that we do really moving forward. So for anyone on the call who's unfamiliar with quality improvement, it's really a way to implement what we know typically as evidence-based practice, right? It takes some time to do research to determine what is the best way to treat patients, but it takes a long time for that to end up in clinical practice. So we can take some approaches that are standardized that help us track whether or not something is successful, sustain it over time to improve practice. And so you can imagine that that can sound very medical in nature, right? Here's an intervention and we want to deliver it to every person in the same way. We know that is not what health equity is. Equity is really determining what individual patients need and how best to get them those services to best promote their health. So there's a few different ways that we can kind of think about health equity in designing and running essentially quality improvement efforts. First is really understanding local data. So Dr. Chung did a great job really illustrating what the data looks like locally, right? In a place like Orange County, overall, the outcomes actually look even better than a lot of California averages, which is fantastic. That is a success that should be celebrated. But when really looking into stratifying that data, seeing where those disparities lie can illustrate opportunities for improvement to deliver specific services to specific communities. And that can really help determine what types of improvement projects or programming is developed. A second piece, especially if access to data is difficult, which we know that it is sometimes, is really including patients and community in both assessing for problems, right? Can we determine what we want to improve on, but then also for creating solutions. What happens, I think, a lot in the medical field and in quality improvement is we say, here's a thing we want to implement and we think this will work for the patient population we're serving. But if we never ask, we won't know that it's effective, and we won't even know that it's solving a problem that our patients report facing. So involving patients and community in both development and project planning is really crucial. And then I think another piece that gets forgotten about when we think about quality improvement is that quality improvement really can also encompass a lot of the kind of care navigation that tends to fall outside of what we think of as medical practice. So we've heard a lot of great programs and initiatives that are happening in Orange County. Ultimately, the healthcare organization doesn't have to reinvent those things. The healthcare organization might not be the best place to provide those services. So can we assess where those services are happening, assess what communities have already available to them, and then be the connector, right? Because we know that a lot of patients are coming to their prenatal appointments, but may not know where to go in the community for their services. So rather than trying to reinvent the wheel as not experts in the community that we're trying to serve, can we instead be the connector to those components and recognize that as part of medical care, as part of holistic care for our patients? And so I think there's a lot of different ways we can really fundamentally think about health equity through that quality improvement lens.
Thank you, Sarah. I wholeheartedly agree with you. I think when we look at what we're doing and how we're doing in Orange County, I think we tend to say, that's great, we're doing a great job, and so our job is done. And I don't believe that. I think that we need to focus on those numbers that for which we're not meeting the needs, and be very targeted and surgical in our approaches to better understand what we may do to further close that gap. the job's not done until we get to 0% or 100%.
Well, and I think you can do both, right? We can celebrate the successes of having good outcomes, because that's always something that we want to celebrate, and then say, and at the same time, now we're going to take all of the ways that we've made improvements in these overarching outcomes and tailor them to the communities who need a little bit extra or a little bit different services than we're already providing.
Absolutely. Thank you, Sarah. Now for Christine, how can community-based maternal health programs be designed to enhance both individual empowerment and collective community building, particularly in underserved areas?
Yes, absolutely. It's such a wonderful question. I'll start with a little bit of an example of what I experienced in the past, and I have a few pointers that I just want to kind of peel back on this. So I'm coming from New Jersey, just to give a little bit of context to everyone. I don't know if I mentioned that at the top in my introduction. So in the New Jersey, tri-state area, Philadelphia, New York, just to give a little background on our data, specifically for Black women in the state of New Jersey, they are at 7 times more likely to have that high risk of pregnancy-related death compared to their counterparts. And when we think about infant mortality, or about Black women and Black babies are about 1.5 times more likely to experience infant mortality, the death before a baby's first birthday. So just giving a little context there, knowing those stats around maternal child health in New Jersey at the start of the pandemic, or I should say the height of the pandemic, we worked with trusted partners in community, particularly the NAACP, the Forum of Black Infant and Maternal Mortality Task Force. We looked at the areas that had the highest rates of preterm birth, infant mortality, maternal mortality, and created this task force collectively with this trusted partner that was known around social justice and around advocacy, and certainly had a lot of buy-in from Black and Brown community members. To that, we added faith-based organizations to the table, and our hospitals and our health systems, folks that might have had stories, good and suboptimal, around maternal child health, and created this really thoughtful task force in different regions throughout the state. And so I mentioned that because I'm thinking about the implication of voice. It's so important to have all voices at the table and representation at the table of those experiences, of the data that Sarah Valancourt just mentioned, those who can bring all different types of background, resources that have interest in really changing this narrative and changing and making sustainable change, I should say. Also thinking about our fathers and partners. I know I mentioned that earlier as well. Sometimes when we do have these task force and we do have these boards, sometimes they could be left off of the conversation. So making sure that they are a critical, integrated part in our conversations. In terms of that individual empowerment, I found when we have these conversations around maternal health, people want to know, what can I do right now? What is the change and action I can do at this moment with this new knowledge I've gained? And so I think it's important to leave people with actionable strategies, whether that is joining a task force or advisory board, or writing a letter to their legislator, really just cultivating those individual ways that we can all make an impact. And then collectively, when we see these advisory boards and task force, the PFACs at hospitals, really those that are really in the interest of making that change could certainly be made as a collective, as long as we have that representation at the table, and including community voices from the beginning, throughout the end, if there is an end on that project, and all throughout, I think is so critical to any structure and empowerment around it. So those would be some of the thoughts I'm thinking. And I just want to leave with one more, that as we are creating these spaces and programs, that we're making sure it's a safe space, that we're making sure that there's trust building. And I know that we just mentioned earlier, trauma-informed areas within these buildings of relationships, and fostering these relationships as well. It's so important, because to Sarah O'Rourke's point, 2 Sarahs here, just making sure that we're dismantling any hierarchies, that we are giving everyone a voice at the table, and even promoting community. The leadership in those conversations certainly helps to dismantle those barriers as well. So wanted to add that in as well.
Great, thank you. Thank you for those comments. Very, very well aligned with what we're trying to do to move up the agendas forward. For Sarah O'Rourke, then, to continue on that train of thought, what role do community-based organizations play in advancing the maternal health equity that we're all striving for? And how can healthcare providers support these efforts?
I think that the role of community-based organizations is really critical. As well, you mentioned some of the workforce shortages. So I think this is where community-based organizations are going to play a critical role. I was on a webinar earlier this week, and they talked about the closures across the state and across the nation, really, in maternity wards and in birth centers. So not only that, but we are seeing these shortages in workforce. Which gives people less options, right? And I think that is something that we need to really be keeping an eye on. I shared earlier that Moms was developed out of a maternal health crisis 30 years ago, and that was because there was a shortage in care for low-income women in Orange County. We were a community development model, and a lot of our model has stayed true to that original intent. That being said, we've also shifted over time because the needs of the community have changed. I think one of the roles that we can play, and I think why community-based organizations are set up so well to help fill some of these gaps, is a couple of reasons. So one is that we tend to hire staff with lived experience that reflect the communities that they serve. And I know that this is true a lot of the FQHCs as well. So I think there's a great synergy there. Again, we also hire staff with a shared cultural understanding, and they have the ability to connect on a personal level with the clients that they serve. We do a great job, and I'll talk a little bit more about this, of addressing social determinants of health. Again, we know that 80% of your health has to do with those social determinants of health and are not influenced by our medical care. So how do we make sure that we're really addressing that 80%? We also really focus on person-centered, I touched on this already, but client-driven care that's provided in a culturally responsive manner. So how do we put the birthing person, again, at the center of the care model? The other piece with the workforce shortage is that the staff that we utilize are maternal child health workers, is what our title is, but community health workers, right? So there's less training needed, and it's a lower cost staffing model. So again, I think it's how do we fill in all these different gaps, because there's community health workers can play an important role. We can add midwives in. And then when clients really need that escalated higher level of care, then we have OBs that are ready to serve them. So I wanted to talk a little bit about what we're doing at Moms to promote maternal health equity. Our model is such that we have monthly visits with a perinatal health worker starting in pregnancy, and that worker follows them through that first year postpartum. So that's a great opportunity for that health worker to be a part of the care team. And that's something that I think is really important to emphasize, that we are part of the care team, and we're here to support OB providers, midwives, whoever's providing that prenatal care. We also are having these extra touch points with our clients, so we're able to catch things that sometimes might get missed. So we're actually visiting them in their home. We're seeing the conditions that they're living in. We're also screening for domestic violence. We're screening for ACEs. We're screening for perinatal mood and anxiety disorders, food security, housing security. So we're looking at that whole picture of what environment is this client living in, and how do we ensure that we're addressing all of these needs. Because if they don't have, if they have gestational diabetes, but they don't have a way to access their, healthy food options, then what's the point of giving these recommendations when we're not following through with support for that client? Dr. Chung also mentioned that we piloted Orange County's first community doula program in partnership with Her Story, Inc. And that allowed us to explore the doula model. And now we have the Medi-Cal doula benefit also that has come on the scene. Very, very excited about the expansion of that model. Moms, we trained all of our staff as doulas with an Indigenous partera, and that was in January. So that was 32 hours of training in lactation, childbirth, and doula support. There's a lot of work happening around doula care right now. I think a lot of work happening around midwifery care as well. And again, it's just filling in how do we utilize all of these layers of care and help people have options in their care. Another initiative that we've recently just launched is a partnership with Baby to Baby and HHS, and we're distributing newborn and infant care kits during the 3rd trimester. Those kits include a magnet from the Hear Her campaign, and that has warning signs during pregnancy and postpartum. really, really important to let clients know what's normal and what's not normal, right? They may be out in the community, and this is where our staff have come in and said, I'm noticing you seem a little off today, or there's something that's different. And we've had clients that had a retained placenta and no one was following up on that because they, maybe they got their postpartum care, or maybe this was before that postpartum visit. So having that extra support. And I really love that Christine also mentioned fathers and partners. How are we including them in the care, right? This is family-centered care. So I think there's a lot of opportunities here for community-based organizations to support the work of healthcare providers. And I think that FQHCs are the perfect place for this because they're based in the community. They have the healthcare resources that we don't have as community-based organizations. And if we can partner together, we can do great things for our community.
Thank you so much, Sarah. All very critical information, and thank you for sharing that example of a community-based program designed by and for the communities, right, that we're striving to serve and impact. And so having discussed all of the discrepancies and disparities and barriers together our communities face, I'm going to ask this question for all of you. And again, we'll go in the order of how you introduce yourselves. What specific policy changes do you believe are most crucial at the local, state, and federal level to effectively address the maternal and child health disparities that we just all talked about? And how can these policies be designed to ensure that they're equitable and inclusive for all communities? So we'll start with Sarah Valancourt.
So I'm not going to pretend to be a policy expert, but I will give a little bit of my thoughts on this question, and then hopefully my panelists will have maybe some more specific policy ideas. I think first and foremost, we have a big issue, even in California, with, like Sarah mentioned, labor and delivery units closing. So we in California, we still have maternity deserts, although much less than other states in the country. And I think the way to think about these closures is that, one, of course, it doesn't serve the community where that closure has occurred, right? So now we're having to travel much farther to get emergent care. But the other component that I think sometimes gets lost in this discussion is that those folks still need to get care and deliver. And so now we have a higher burden on other existing or continued services in other organizations. It very much ties back to that workforce discussion of now the burden is higher in organizations that might already have staffing issues. And ultimately, that just doesn't serve any patient, any organization. So really trying to figure out, the way that we can kind of stop the bleeding on that. So we're not continuing to have these closures because it is an issue that will continue to compound on itself. I think that is a very urgent problem that, again, I don't know the policy solution for, but I think understanding the problems is important. Maybe a little bit less urgent, but in the conversations about, how Medi-Cal is changing the way that we're thinking about reimbursement outpatient for services. One of the things that I think would really aid outpatient quality improvement, and this could come from a regulatory perspective, is how are we incentivizing quality metrics for pregnancy and postpartum care in a way that helps financially incentivize medical organizations to update and innovate and really move towards that kind of quality-based alternative payment structure, since we're moving in that direction anyways. I think that this model works really well for primary care, where we want to have certain A1Cs for our patients with diabetes and well-controlled hypertension. Are there ways that we can more effectively create these quality metrics for pregnancy care? The example I always use is we have a metric for timeliness of prenatal care, right? So we want to get patients in before 16 weeks. That's a great metric, but what it doesn't measure is then any utilization of care after that first appointment. So we're not effectively incentivizing organizations to make sure we have continued touch points for those patients. So I think just thinking creatively and in a way that aligns with how we're moving towards value-based payment models would be helpful to make sure that our patients are getting all of the services that they need in the outpatient realm. Oh, I think you're muted, Isabel.
Sorry. Thank you, Sarah. Thank you for that. I'm going to add something that somebody may come up or bring up later. I think it's critically important for us to also recognize that we're still in an era where women are not necessarily entering prenatal care at the 16-week or before the 16-week mark. There continues to be women that are entering late stage, and then that causes another problem, because on top of the workforce shortage issue, then you're also stuck with the increased liability, right, for OBs wanting to or being able to take you on, one for prenatal care, but also where do you give birth, and who's willing to see you before you're actually in labor and you have to go in through the emergency room, right? And so I wanted to call that out because that still happens everywhere, even in Orange County, right, where our numbers are quote unquote better than other areas. At this point, I also want to give a quick shout out. I don't know if we have any Altamed staff on the call, but in Orange County, Altamed Health Services continues to be the entity that no matter what stage, 30 weeks, 31 weeks, 35 weeks, they will always make sure that the patient gets into care and with the guaranteed delivery at local hospitals. So again, I didn't want that opportunity to pass without me stating that, because it is still an ongoing concern. And so along the same lines with the policy questions, so I'll go over to Christine.
Yes, I have a few thoughts on policy. What Sarah O'Rourke mentioned in her explanation of a community center program is certainly where my mind positioned for this portion of policy. I'm thinking about the integration of CHWs, of doula, of our home visiting programs, and making that a regular occurrence for all of our states from a national perspective. I know I'm coming from that East Coast, and we have a lot of great reinforcement and support around that. But just from a national perspective, I think that would be something that would be very extremely valuable. We know that when doulas are present, from a full spectrum approach, or even from postpartum, we see like there's so many great birth outcomes and pregnancy-related outcomes that come from that, particularly for expectant mothers and birthing people, and the reduction around preterm birth. And we saw that there's alignment in studies around that. So certainly supporting the workforce. I know I'm saying a lot around workforce development today. But I don't think that could be said enough. The support, and then with doulas, making sure that there's a reimbursement for the great work that they do, and of course a livable wage for our CHWs, for our home visiting staff, for our doulas, and so on. I mentioned this a little bit earlier, but for our upcoming professionals that want to be involved in health, just knowing about different options that are there. For those who, or let's say that are physicians in their residency programs, or wherever folks lie within their medical journeys, also thinking about what's being taught. We know that so much in the pregnancy space is deeply rooted, and so many issues that we could talk about all the way back to slavery days, and so much that we've seen in racism that have been rooted, and really just taking a moment to see where we are in the future, but know that a lot of that future reference can be perpetuated from the past. So dismantling and having that anti-racist training and forms of training is so important, I think, and critical. So that goes back to our conversation earlier about implicit bias training, that it's not necessarily like a one-time checkbox, that we have that on a reoccurring basis. Culture, humility, same thing with that as well. Just really recognizing how our providers, our staff, anyone who touches the maternal health space, as I say, has that really in-depth training. In New Jersey, we're doing some wonderful work, and it's actually a national program that we're partnering with Ariadne Labs of Harvard University and their team. You all might have heard of Team Birth, which is a really great model that helps to really think about shared decision-making. So how staff communicate with other staff and providers within hospital systems, but then also how our providers communicate with our patients as well, and uplifting that decision-making where the patient is centered, as we talked about earlier, but then also empowering each individual on the care team. And so thinking about structures of that professional development and continuing to course correct anything, because we know that providers give wonderful care. A lot of this care is done every day on the daily, but just making it in a way that's structurable, or has that structure rather, and that's consistent with that communication, uplifted and amplifying communication from the patient is important as well. So I just think about that full landscape there with that communication and who we have for our workforce and developing that for the future.
Thank you, Christine. Critically important as well. Sarah, over.
Yeah, this is a great question. I wanted to just say, we've done a lot of work in California in expanding Medi-Cal coverage, and I think that's huge to getting people into care. So I think there's a lot of great work that's happening. In the interest of time, I just want to point out, and maybe we can send this report out, but there was a great report by the National Partnership for Women and Children that highlighted 3 areas to address maternal health equity, and those were midwifery care, doula care or doula support rather, and then community birth settings. So we talked some about the doula piece already, and there is the new Medi-Cal doula benefit. Still a lot of work to happen there, but I think that's a huge win for California that we've adopted that statewide for anyone that has Medi-Cal. There's others that we need to fill in. There's kind of people in that middle income range that really can't afford a doula, but also don't have Medi-Cal coverage. I think there's still a lot of work to be done, but we've made great strides there. I think I'll continue to emphasize the importance of midwifery care because that's one that we're actually seeing that workforce decrease right now. There's more and more kind of gatekeeping, if you will, and more barriers to having midwives be part of the care team. Not everyone has access to hospitals, which is hard to think about in Orange County because we're so well resourced. But there are other parts of California that people are in rural areas and they can't easily get to a hospital. So how are we serving those folks? There was on this webinar earlier this week about, really looking at birth centers and community-based birth settings. There's a requirement in California that birth centers be located within a certain mileage of a hospital. So what about folks that are outside of that range and there's really no care options for them? So I think we really have to be creative about how we layer in all of these different supports. Again, I'll go back to, I think community health centers are so important in this work. They already have so much of this infrastructure in place. And I would encourage all of the health centers to really look at considering to hire midwives and incorporate doulas as part of your care teams. Look at your home visitation programs and CPSP services. A lot of the health centers do offer that. So I think there's a lot of work that can still happen. Here in Orange County, we have Cal State Fullerton that has a great midwifery program. Right across the border in LA County, we have Kindred Space LA, which is a beautiful model that I highly encourage you to check out. So a lot of great work happening.
Thank you, Sarah. We have another, and thank you so much for both Sarah's and Christine for continuously highlighting that this work is done great at an FQHC space, right? Because that was the design back in the 60s, right? To create the community health center movement to make sure that community health centers were where patients were, where the community need was. And again, this is critically important to make sure that we have these resources available to the targeted communities, not only again in their language, culturally competent, affordable, but where they're at, so that we can reduce some of that barrier that we have with transportation. I have one more question, and so I am trying to see if I have time for that, or do we move on to Dr. Ramos? And so in light of the fact that I don't have a message yet, I'm going to move on to my next question. And so this next question is for all of you again, and we may not be able to get through to all of you, but from your perspective, and I'll start with Sarah Valancourt, and looking toward the future, what key actions that will be most impactful do you believe stakeholders can or should take over the next 1 to 2 years to create a more equitable maternal healthcare system? So short-term goals.
Right. I'll answer those quickly. I think to kind of reiterate what a lot of the conversation has been is our healthcare organizations need to connect with the community-based organizations. There is great work already happening. And so reaching out, making those connections so we can kind of serve patients immediately is really important. The other advice I have from a quality improvement perspective is to actually start small. I think when we talk about health equity, it's this big kind of overwhelming, in maternal health crisis, it's this big giant problem and it's something we need to address. But what healthcare organizations can do is start small. You have patients who are pregnant today and need you to do your best job today. So what can we do to improve the way that we're delivering services to most effectively serve our patients? And what you'll find is when you do quality improvement in that way, it does tend to gradually build capacity over time. So we get to the point where we can solve the big giant problem after we're doing these kind of smaller interventions that build upon each other. So those are my two recommendations for short-term goals. And I think those are feasible kind of when you start thinking about the now.
Thank you for mentioning that even small goals are important, right? We just need to get started in moving the ball rolling. So we'll go over to Christine.
Sure, absolutely. I'll keep mine brief as well. I think adding on to what Sarah Valancourt just mentioned is we say it a lot, and thinking through this, I think, is listening to our community as well. Listening and looking for actionable strategies, I think, would be my two pathways. First, listening to community. I mentioned earlier, if we're developing a program or initiative, really having community in the midst of those conversations at the beginning of the planning stages, throughout the program or throughout the initiative to see how it's going, even hold a focus group or informal discussion. And then at the conclusion, having that input and feedback as well. So all throughout each of those spectrums, I think, is extremely important. I mentioned the Black infant and maternal mortality groups that we made in New Jersey. And from that and listening to community and really having our finger on the pulse and listening and just taking a moment to digest what they meant and what they were saying, is that they wanted an area where voices could be shared and a safe space to do so. And from that, we all created a survey that reached BIPOC people throughout the state and allowed folks to do that in a safe space to make sustainable changes in policy. So I say that just to say, sharing the voices, make sure that they're amplified at the table, and then looking for actionable strategies where everyone could be involved in evaluating the progress over time, I think, is extremely important.
Thank you, Christine. I think it's invaluable to continuously seek the input from the communities that we're trying to serve. I've heard time and time again when we're invited to the table to co-design that we want to make sure that nothing about us is done without us, right? And so we may get comfortable in spaces where we may think, well, we did that survey 10 years ago and we know what community needs. There's a lot of changes that happen throughout this time period. There's generational gaps, right? What may have worked with Gen Xers may not work with the alphas and millennials and whatnot. So I think it's critically important that we're always creating those safe spaces for the communities to feel that they can share their thoughts and feedback. And not only will they get listened to, but something will be done about it versus shelving that nice and shiny study somewhere on a shelf, right? But we take action on it. So thank you for that. Sarah O'Rourke?
I'll just briefly circle back to my original comments, which, I think it's a shift back towards seeing birth as a physiological event. It's the one, condition, if you will, where you go to the hospital typically as a healthy person. And I think that is, where it's kind of this different approach. So how do we trust birthing people that they know best? How do we kind of rethink the power dynamics and the relationship between that collaborative care team? So, that can include the OB, the doula, your community-based partners. So how do we all work together, right? And I think that, again, we've talked about so many models, so much great work that's already happening, but how do we really integrate that work and, address the social determinants of health, but bring it all together, because at the end of the day, I think we all play an important role and we can't do this work alone. So I think that would be my key takeaway is just how do we continue to work together, because this is too important to miss.
Thank you so much, Sarah. And again, right on time, I believe we have our Dr. Ramos on the line, our covering Surgeon General. But before I go to her, I just want to give you all a heartfelt thank you to all of our esteemed panel speakers for your insightful contributions, the dynamic discussions during this coffee chat. I think your expertise has truly illuminated key aspects of today's topic. I really wish we would have more time to go deeper down this rabbit hole of how do we really address, some of the barriers and the disparities that we've all highlighted again. And again, we're preaching to the choir. We all know what the issues are. We need to focus more on the actionable steps of how do we continue to reduce those gaps. So having said that, it is my pleasure to introduce the special speaker for today, which is California Surgeon General, Dr. Diana Ramos. Dr. Ramos is a renowned public health leader, the first Latina to hold this role in California, and a passionate advocate for the health and well-being of all Californians with a particular focus on maternal and child health. Her 3-decade career as an obstetrician, gynecologist has provided reproductive care to thousands. Her remarkable career from providing care to shaping public health policy at the highest levels speaks to her dedication and expertise. Please join me in welcoming Dr. Ramos for her special remarks.
Thank you so much for the invitation to participate on the Coffee Connect, focusing on maternal health, a pathway to health equity. I've been on the line and have been listening, and I'm inspired by all the work being done in Orange County. And as California Surgeon General and an obstetrician gynecologist, I have heard from many and seen firsthand how maternal health disparities impact perinatal outcomes. Maternal mortality is a pressing issue that's impacting our nation and our state. And California has made progress in reducing maternal mortality. And you probably already know we have the lowest maternal mortality rate in the country. However, we're still losing too many mothers, especially Black mothers, who are 3 times more likely to die from pregnancy-related complications, more so than white moms. Now, that's not just a statistic, it's a call to action. And the harshest truth, in California, more than 80% of these deaths are preventable. Preventable, we can save a life. This is already a tragic situation, worsened during COVID, because in California, between 2020 and 2021, almost 48% of the pregnancy-related deaths were from COVID-19, almost half. These complications deepen the maternal mortality crisis, leaving lasting impacts we are only beginning to understand. And recent data on how a single suicide can impact up to 135 lives is bringing to light the far-reaching effects one life can have on many. This underscores a larger truth. While we recognize the profound impact of a mother's life, our efforts to address these challenges have been fragmented. The problem isn't that we lack the solutions. It's that for far too long, we've worked in silos. Hospitals have protocols, public health have policies and programs, and community organizations offer support, but they're all operating separately. The result? Gaps. These gaps have put mothers at risk, and that stops now. That's why on Tuesday, September 17th, my office is launching Strong Start and Beyond, and I know you saw the video in the beginning. And this movement is focused on 2 simple outcomes: decreasing maternal mortality and providing the opportunity for active participation in your health. And this is for the community, and I'm hearing this message over and over. Since 2005, California has been addressing maternal mortality. When we began our maternal mortality reviews and developed cross-collaborative partnerships in pioneering and developing maternal care toolkits. Those toolkits have helped physicians, their health teams manage emergencies like hemorrhage. These toolkits developed here in California are used globally and have saved countless lives. But they aren't enough California's success has been largely a result of the work focusing on the healthcare setting. And that's why I'm so pleased I've had a chance to listen to your conversation, because elevating and including a patient's voice is an essential part of comprehensive medical care. If a person feels their concerns aren't taken seriously, this erodes trust, and they may not come back to seek the care they need until it's too late. We've heard the stories of mothers who weren't listened to, who weren't believed, and who paid the ultimate price for it. And while Black women bear the brunt of the crisis, maternal deaths are rising across all ethnicities here in California. And that's a system failure. And we're determined to fix it because we are California. Our solution is outlined in the California Maternal Health Blueprint. Now, this blueprint is going to be released next Tuesday, and it sets the framework for Strong Start and Beyond. The surge in deaths during the pandemic underscored just how vulnerable expectant mothers are. And maternal mortality isn't just a California issue, it's a national and a global issue. What we're doing here in California will be a model for all. In California, heart disease is the leading cause of maternal deaths, followed closely by behavioral health issues, and that includes mental health, substance abuse. Black women and Hispanic women are disproportionately vulnerable to chronic diseases that increase their risk, but no one is immune. These aren't isolated problems. They're happening everywhere and demand a unified response. And the solutions we are creating in California are simple: collaboration, prevention, and listening to mothers. All of this can be replicated everywhere. And Strong Start and Beyond is incorporating the component that has been missing and really has oftentimes been overlooked. And that's the patient's proactive voice and participation. And that starts the continuum of wellness from preconception to prenatal and beyond. Our solution begins with an easy pregnancy risk, medical risk assessment that you will be hearing more about. And that is going to give people the opportunity to know, if I were to become pregnant right now, what would be my medical risk? Would I be high risk or would I be average risk? Up until now, unless you have that preconception health visit, you really don't know. We're going to be changing that. So thank you so much for the opportunity to share a little bit about what we are going to be starting and launching with Strong Start and Beyond. A lot more details will be unveiled and they'll be forthcoming. We're not creating any new programs, really important to know. But what the California Maternal Health Blueprint will be doing is elevating participation and awareness of already existing programs that will enhance health outcomes. So we look forward to your participation. On the QR code right behind me is the link to pledge your participation to Strong Start and Beyond. And I hope that all of you go on that code and be part of the solution for California, because we know that together we are stronger and together we can bring in our community voices, what we're doing really well in our space, and really make California a healthier place for all, especially the most vulnerable, and that is moms and babies. So thank you so much for the opportunity to be here, to listen to you, and let's continue on together in health. Juntos en salud.
Thank you so much, Dr. Ramos. I specifically look forward to learning more about the Strong Start and Beyond Blueprint and how we may align to that blueprint again at the local level. And I know that our healthcare agency and all of our partners in the county will be monitoring that closely as well, so that we can again bring some of those strategies to reality here. I appreciate you stopping by and making some time to be with us today during this important conversation. And so as we draw our Coffee Connections event to a close, I want to again extend my heartfelt gratitude to each and every one of you for your active participation and thoughtful contributions throughout our discussions on maternal health, a pathway to health equity. I love that we end with opportunity to look forward to this blueprint that's going to be unveiled next week, because I don't like to have conversations where we just talk about the problem and admire the problem, but rather find out how we can participate actively in addressing that problem and actionable solutions. So thank you again to our speakers and our audience. I want to leave you with two key insights, or a few key insights. And I'm going to quote some of you. So to quote Dr. Chung, the best investment to ensure the health of a newborn is to ensure the health of the mother. And Dr. Chung shared federal, state, and local resources, which will be shared with participants post the webinar. She also challenged us to think about where in the systems you work, that you can impact some of the White House blueprint goals for addressing maternal health crisis. If you think about where you're at and what you can do at your level to raise those issues. Our panelists also shared some of the critical barriers and how we can come together to overcome them. This included the lack of service integration sections, and also within the medical field, to shift away from seeing birth as a normal physiological event and not a case that needs to be managed medically. We need to put the birthing person back into the drive seat and focus on client-centered care. We talked about social determinants of health and how we can think about upstream, downstream, and midstream approaches. Our panelists also gave us great advice on how to address the maternal health crisis. Start small, have patients that are pregnant today. How do we provide the best care now? Listen to our community. I think we talked a lot about that, and look for the actionable strategies. Trust birthing people that they know best, and rethink power dynamics and hierarchy. And of course, lastly, Dr. Ramos shared that including the voice of the patient is an essential part of comprehensive health. We all heard about the announcement of Strong Start Beyond on Tuesday, the 17th. You all saw the QR code. We'll be sharing that as well after the webinar, so everybody has it in accessible fashion. And so thank you again for your participation and your dedication and your commitment to creating a better future. We look forward to seeing you at our next Coffee Connections event, scheduled for December 6th of this year, to discuss the future of healthcare post-election year. This will be an in-person event. This will be our first in-person Coffee Connection event, and we hope to see you all there so we can have this wonderful discussion after our election this year. And then, of course, we at the Coalition turned 50 this year, and we hope to see you all at our 50th anniversary gala, which will be held on November 21st, 2024. And we have in the chat shared a link to the registration and sponsorship materials and all that good stuff. I am looking forward to seeing you again at our next event. Thank you, everyone. Have a great rest of your day and have a great weekend.